Dear Facebook Pure Urology viewers, good evening one and all. As you all know, daily we are doing one technique based presentation in urology. Today we are discussing about the penile curvatures and how to correct them, when to take it for surgery, when to not to take it, selection criteria, etc. will be discussed by Dr. Shailesh Shah sir, who is very senior urologist from Ahmedabad, very well known urologist in the Urology Society of India, with a lot of experience in the government sector as professor and the private sector as the practicing surgeon. Let us listen from sir, who dedicated his life in the to the urethroplasty, advanced reconstructive surgery of the urethra, and also penile curvature repairs. Good evening, sir. Dr. Shailesh, sir.
Good evening, Chandraman.
Sir, I wanted to know where was your MCH search to start with. After brief introduction, I will hand over the program to you, sir. You did your MCH from which place, sir?
I did it from Christian Medical College, Vellore, way
Of
back
PMC.
in 88.
88, sir. Okay. You did your MS, sir?
I did my MS from MP Shah Medical College, Jamnagar. That was the time that in entire Gujarat there was no MCH program. And
Okay.
even for MS also, you have to go region wise. The state of Gujarat was divided into 4 5 region, and you go to your regional medical college. Unlike it became open after about 10 years when I did MBBS. So where you can
Your
select
MBBS is from, sir?
MBBS and MS both from MP Shah Medical College, Jamnagar. It is
Jamnagar. Yeah. Okay. That is
Jamnagar.
nearer
Yeah,
to your native place.
yeah, correct.
So you have that at that time you had entrance examination to select, or intermediate mark based.
No, it was on the basis of the after we had a 11th metric and then we had a pre-university science. So on the basis of the mark, I was a center first and in first 10 in Gujarat state. So
Okay.
so accordingly I was selected, and then I had a couple of gold medal in MBBS and then MS general surgery gold medal. But as there was no super speciality, and in Saurashtra there is a lot of urological work, mainly it is full of stones.
Okay.
So that was a time when we used to do lot of open surgery even during MBBS and MS.
So during your MS time, what were the most common surgeries, general surgery performed? Duodenal perforation, appendicectomy, hemicolectomy, like that?
Yeah, yeah. Apart from that, the commonest was pylolithotomy and
Pyelolithotomy by
spironectomy.
general surgeon.
Yeah, yeah.
Who was your mentor in CMC Vellore, sir?
I Dr. Ganesh Gopal Krishnan and Dr. A.P. Pandey. I was a student of A.P. Pandey, but as you know, Ganesh was that was the first batch. After about 5 6 years of the gap, the MCH started. My colleague was Dr. Viswambar Nath. Now he is in Hyderabad only.
Yes, sir.
Earlier,
Yes, sir.
yeah. So he already had done his DNB urology, but being a first MCH after about 6 7 years, if you remember, Dr. Bhatt suddenly left CMC, and then Dr. Ganesh had to move to the various part to finish his MCH. And for 3 4 years, there was no MCH in CMC Vellore. And when I joined, it was a first year after a gap of 7 years. At that time, A.P. Pandey, Ganesh Gopal Krishnan, Vishwambar Nath, Nitin Kekre, they were my teacher. Nitin was 1 year senior to me. He had
Okay.
done DNB.
Very nice. Great, sir. So I didn't know that Ganesh Gopal Kishan sir is also a little bit part of your contemporary and teacher as well.
No, no, he's senior to me. He's my teacher.
Teacher. Okay.
Yeah,
Very
yeah,
nice.
yeah.
After when did you learn your PCNL, sir?
After I finished, I mean, when I was also doing my MCH, Ganesh was just learning PCNL, and we have seen he's trying and doing it in CMC Vellore. And then I came to Ahmedabad. First 2 years, uh, because in Ahmedabad there was we started a teaching program within 2 years. Under me, DNB urology started, and Dr. Trivedi started a 200 bedded nephrourology institute. So we could get all the equipments apart from kidney transplant. We
Which hospital, sir? This is you joined as assistant professor.
is Institute of Kidney Disease and Research
IKD.
Center, IKD.
Oh, so
I
called IKD now.
I was the founder professor of the IKDRC, where people look for the a lot of experience as a DNB candidate. They come now. Now it is a Gujarat University of Transplantation Sciences, and there are 4 seats of DNB in IKD.
So you are the first assistant professor for that DNB program.
Yeah, I was the first assistant professor. Then after about 3-4 years, we requested DNB, and Dr. Bhandari came, and he requested Dr. Trivedi to give me post of professor. So I was the youngest professor in state of Gujarat and maybe in country at that time. And as a full-time professor, we started first DNB course of state of Gujarat. Even with due respect, Dr. Mahesh Desai's program started DNB after IKDRC program.
Oh, great. So after you joined your career, because you did from CMC Vellore, how you modulated your career towards the ultimately we remember now last 5 years, 10 years after I passed my MCH in 2006. More or less we remember you as reconstructive surgeon. When did this happen in your career that you moved more concentration on reconstruction?
Uh, to Initially, because as a urologist we have to do everything, and as you asked me when did you learn your PCNL, we purchased PCNL instrument sometime in 90, and then I learnt it myself being in the medical college and students with you. We did a PCNL, and then I went to Cleveland Clinic and learned a laparoscopic urology. I had gone to Coimbatore also, and there also I learned some laparoscopy, and we were the first in western region to start kidney donor to be done by laparoscopic. So I must have done more than 2000 laparoscopic donor nephrectomy during my study.
Oh, great. I didn't know this, sir. So then urethroplasty it was part and parcel of your career from beginning.
Working with Ganesh Gopal Krishnan, I was interested, and honestly speaking, Gujarat is a hub of urology. Ahmedabad and Naryad Institute being the biggest institute in Ahmedabad. At that time, IKDRC had a equipment, but they are not in comparison as good as MPUH Naryad. And I was working with Ganesh. I was always interested in urethroplasty and surgery. So sometime in 93, 94, Professor Woodhouse picked me in Bombay, UCCon, where I presented reconstructive surgery in chronic renal failure, because we were getting many CRF patients. So he told me that if you are interested so much, we have a international reconstructive society like GURS. So I will take you as a fellow there in London. There was a first meeting in 94 in the London. So he took me as a invited guest there, and I attended first GURS meeting. And then my interest grew, because every year there was a workshop somewhere, either in Germany or in the Europe, anywhere, and this live operative workshop for 4 days was helping me to learn a different kind of a reconstruction.
In fact, you are conducting workshops recently on penile reconstruction pen recon, no, sir?
Yes, sir. Yes.
Last time Corona it is postponed. Otherwise, it was happening every alternate year or year.
Every alternate year.
Yeah.
And and people were because many delegates come, mainly because we saw the surgery of urethroplasty, hypospadias, epispadias, and also the penile curvature, penile prosthesis, and we also included in 1 year female reconstruction also. So most people are like, yeah, you guys are very good technically in laparoscopy, RIRS, and other endourology, but a general urologist who practice in India, especially not so big city like Ahmedabad or Hyderabad, but if they are in a middle type of the town, they have to do everything. So
Yes, sir.
generally, urologists have to learn most of the technique, and reconstructive part is also about 30-40% of the urological surgery.
So last question, sir. When did you taken retirement for this or voluntary VR from the IKD and went to practice? And I also heard that your son is also MCH now, a proud moment for you. He has finished, I think. And these two you address, and then we will go to the talk, sir.
Yeah, I uh, the over the time we started the kind of a hospital which you are having. Ours is about 50-60 bedded bodyline hospital,
Sir.
and similar to you, we worked a lot for COVID also.
Yes,
At
sir.
that, Dr. Trivedi, H.L. Trivedi was always believing that Trivedi was the nephrologist, and he was
Yes,
the
sir. He is a
director.
very famous person to develop the IKD.
Exactly, exactly. Now he is no more,
Yes,
but
sir.
but at that time he wanted full time to take over. So we have like Pranjal is my first student, a couple
Great,
of
great.
two students. So Pranjal Modi was a very hard working, and he took over. And at that time, sometime around 10 years back, I voluntarily retired after my 25 years of the working in IKDRC, and then I am full time working in my private setup.
Great. So,
Utsav is my son, as you asked me,
sir.
and I a lot of things are happening in the family and into the doctor's family as
Hello.
engineering. Hello,
Yes, sir.
am
Yes,
I? Are you
yes,
able
sir.
to?
Yes,
Are,
yes, yes, yes.
okay. So Utsav did his MBBS MS from Ahmedabad, and then he did MCH from SRMS Chennai, and
Okay.
then after that he wanted to do he was selected for AUA fellowship also, but unfortunately even AUA didn't happen. Now this year it is there in Las Vegas, so let us see whether he can go there or not. But he has been selected for a postdoctoral fellowship for uro-oncology with robotic surgery.
In SGPJ.
Yeah,
So with that great track, all the juniors will get motivated. Everybody has to start career like this after passing MCH. Not everybody may not be directly going to the bigger institute. Everybody has to work hard. Taking your this small 5 minutes as an enthusiasm and encouragement for the juniors, so we will hand over the program to you, sir. I will formally introduce you on the screen, and then I will hand over the mic. So, dear Facebook Pure Urology viewers, this is Professor Dr. Shailesh Shah, who is the Chairman, Managing Director, Consultant Urologist, Bodyline Hospitals, Ahmedabad. He is the first orthotopic kidney transplantation of India performed and presented in international video conference. He regularly organizes very popular workshop Pen Recon at Ahmedabad related to reconstructive. I hope as soon as the pandemic is over, he will start back again. Many people suggested. In fact, my team has to go. They have paid registration fee also, but unfortunately, last year did not happen. Editorial member, Indian Journal of Urology, year 2007 to 2009. Examiner and inspector, National Board of Examination for 20 years. He has presented or not to national and international papers. He published over 20 articles nationally. Late Professor G.M. Phadke Traveling Fellowship awarded by Urology Society of India. CKP Menon Award Best Scientific Paper 1987. President's Gold Medal by Urology Society of India, West Zone. Thank you very much, sir, accepting the invitation, being very senior. Over to you for the presentation, sir.
Are you able to see?
Yes, sir.
Okay. So, first of all, I am thankful to Chandramohan. I had a very good memory of him. When we went to Hong Kong for a research meeting, he and his wife were together with my wife and me, and we had gone to Macau together, and we I had a wonderful experience of being a friendly and very patient person. The surgeon who is a as a surgeon, he is a very aggressive and always eager to learn new things. But as a friend, when we lost our camera, he helped us a lot. So I know him that way. When you go out of the country and being a urological colleague, being with you for a couple of hours, and you enjoy the company, that is a quite different experience. Thank you very much, Chandramohan, to call me for this.
Thank you, sir.
And I am also impressed with your capacity of working and learning every day. You handle the private setup. Now you have a 3 4 hospital, and simultaneously you have made this pure urology program very popular. So I'm really proud of you. Thank
Thank you,
you
sir.
again.
Thank you.
This is
Sir, first click, sir. One click you do, after that it will roll down.
where do you
On the screen you click once.
okay,
Then you roll. Next. Yes.
okay.
Yes, sir.
So the definition of mon, penile curvature, they are mostly caused by disproportionate growth of the corpora cavernosa. It could be congenital curvature, or it could be Peyronie's disease or traumatic. Now, when you have a CPC, that is a congenital penile curvature. If it is a downwards, it is hypospadias. If it is dorsal, it is epispadias. But we are talking about monosymptomatic. When I started pain recon, honestly, I didn't know that there could be a patient who had monosymptomatic penile curvature from birth, and this patient can come to you at the age of adolescence or sometimes as a unconsummated marriage. Now, CPC, which is monosymptomatic, is often ventral and lateral, while in Peyronie's disease, you get a dorsal and lateral curvature. Patient come to you because they can't penetrate vagina and there is a painful cohabitation for sexual partner. I have seen couple of patient after marriage for about 5 7 years they have tried, and gynecologists and urologists have not understood because of the curvature of the penis they had a problem. Now, as far as Peyronie's disease are concerned, most of us see the patient in a different stage, but as as I know today, very few are operating it because of the various reasons. Now, the indication of surgeries are once the disease is stable, minimum after 6 months of the stable disease. It means when there is a no pain, it is a painless deformity, and it is a compromised or person is unable to engage in coitus. If that much is if he has a plaque and he is able to have intercourse, it is not an indication of surgery. Failed conservative therapy, and when there is an extensive plaque calcification, there are patients who have a desire for rapid and reliable result, because as far as medical treatment is concerned, there is no rapid and reliable treatment. Before I discuss the different kind of a modality, Chandra, is it okay? Sound is not there.
Hello, everything is okay, sir.
Okay. No, right.
Only thing is that slide is moving faster. You are clicking the slide now, sir.
Yeah, I am clicking. I thought,
Okay.
yeah. So
Okay.
I'll take some time.
Yeah.
Now, first of all, before I discuss, I'll tell you what the guideline are telling. This is European Association of Urology 2021 guideline. As far as the congenital penile curvature is concerned, people who are watching right now, sometimes they might have seen a patient who come to you because there is a curvature of the penis, and if you examine, you may not see any plaque at all. There is no history of fracture of the penis, and these patients are having actually congenital penile curvature because the disproportion. Now recommendation is you need to use a plication technique, and currently there is no optimum surgical technique, but plication technique is recommended as a first line of treatment with or without neurovascular bundle dissection. It all depends whether you have a dorsal or a ventral curvature. So accordingly, you elevate and dissect the neurovascular bundle. Now, as far as a Peyronie's disease is concerned, the standard guideline recommendation is the disease has to be stable for at least 3 months, and it should be 12 months from the onset of symptom to take the patient for surgery. You need to assess penile length, curvature, ED, everything, and what is the patient expectation. This part is very important as far as the Peyronie's disease surgery is concerned. Tunica shortening procedure is the first treatment. In India, I suggest and I'll be repeat time and again that tunica shortening procedure, which is a penile plication surgery, is a first priority both for CPC as well as for the Peyronie's disease. And it can be done in a non-severe curvature and in absence of complex deformity like hourglass or hinge deformity. The type of procedure used is dependent on surgeon and patient preference. This part we will cover little later on. Use tunica lengthening procedure patient with PD and normal erectile functioning. When you are, see, one is a tunica shortening procedure and another is a tunica lengthening procedure. If you are using lengthening procedure, patient should not have ED, and if there is a ED, you have to take certain other precaution or choose the other type of surgery. There is a one sliding technique which you do for a patient with very severe ED as well as PD, Peyronie's disease, but it should be used very cautiously because there is a possibility of glands necrosis if you do elevation of the neurovascular bundle. As far as possible in 2021, now the guideline is do not use synthetic graft. In between, the synthetic grafts were considered as comparable to the autologous graft, but now the guideline says that don't use synthetic graft. Use penile prosthesis implantation with or without any additional procedure in PD patient with ED which is not responding to pharmacotherapy. So if you give a pharmacotherapy and if it doesn't work, then they are not the patient only for the Peyronie's disease surgery. You have to go for simultaneously prosthesis. Now, evaluation is done on the basis of degree and complexity of the curve, baseline penile length, percentage of estimated loss of length after the correction, and baseline erectile function. Once you evaluate this, and every time when you take a patient for the surgery, first take the length like this and give one photograph to the patient and keep it with you, because this patient, whatever type of the surgery, whatever fantasy he has in his mind about the size of the penis, he will come back to you that my penile size is reduced, especially in first 6 months of the surgery. After that, it becomes normal. That part we will cover when we see the video of the plication of the surgery. Remember, the aim of the surgery is to improve or straighten the penile curvature, and it is not to treat the Peyronie's disease or erectile dysfunction. When we are talking about penile curvature, then our aim is to treat the curvature. But we have other things also together. So that also need to be handled, but it is to be handled differently. As far as the curvature surgery is concerned, our goal is to straighten the penile curvature. Now, what are the different discussion we do or consent we take? We have to first set expectation regarding the outcome. Goal, we discuss with the patient that you need functionally straight penis which is less than 20 degree. Some of the young people do come to us when they know that I do penile surgery with a 10 or 15 degree curvature after they see the pornographic picture or video that they have a curvature, but you have to measure the curvature. If it is less than 20, then usually the penetration is not a problem. So you have to tell them that when you do the surgery for 60 degree or more than that, then you will come up to 10-20 degree. It should be functionally straight. Now, after the surgery, there will be change in the length. It is more likely it will become shorter, especially when you do plication surgery. Now, if a patient is having a minor Peyronie's, or if there is a not significant curvature, but he is very clear that he doesn't want his penis to be even a little shorter, then probably we have to choose the second type of the surgery, which is a grafting. So change in the length, but it is not a significant change in the length. But if a patient is ready initially, then only you can do it. Diminished rigidity, 5% in all study, especially with grafting. If you do plication, rigidity doesn't reduce because you don't cut the tunica albuginea more than 30% if suboptimal preoperative rigidity. Now, if you have a patient who already require a pharmacotherapy and if you do grafting, then their rigidity will reduce in 30% of the patient. But remember, still 70% of the patient do well when you are cutting the plaque and grafting it. Common is a decreased sexual sensation. It is there for about 3 to 6 months, but later on it goes away, especially because you cut the penile skin and nerve endings are affected, but it will never compromise orgasm or ejaculation. Now, when you treat a penile curvature, you have a two major group of surgery, tunica shortening versus tunica lengthening. Tunica shortening procedure are for the patient having a simple curve which is less than 60 degree. There is no hourglass or hinge deformity. This deformity you see in the case of Peyronie's disease, which is very bad, where you have a 2-3 different plaque. And when person is ready to reduce the length, which could be maximum 20% of the total erect length. Now, tunica lengthening procedure is offered for the complex curve when it is more than 60%, and especially in hourglass and hinge kind of a Peyronie's disease, you need to go for a tunica lengthening procedure. Goals we have already discussed, but again to reassert, functionally straight erection to preserve or improve rigidity, and one will always try to minimize the shortening. There are various type of the plication, but the plication which we are preferring, which we are now suggesting, will is the kind of application which perhaps do not give any shortening after 6 months. Initially, the shortening up to 1 centimeter will be there in first 3 months. So some variation due to patient preference, we have to change the kind of the surgery. Now, when you talk to the patient or when you start the surgery, usually measurement of the short side should predict the length after the Nesbit procedure. Nobody does Nesbit procedure nowadays, but Nesbit procedure is the first gold standard procedure for the shortening, for the penile curvature. We will talk about it, why we don't do Nesbit now. We, instead of that, we do other modification of the Nesbit. Measurement of the long size after grafting, the long side of the penis, as if this is the penis, then this is the long side, so long side will remain after the grafting. Let us talk about the plication procedure. The first and gold standard is Nesbit procedure. Second is a modified corporoplasty, which is known as a Yechia corporoplasty, which is kind of a hinge maculus. MPP is a multiple parallel plication. We have called the surgeons from Sava Heroic Foundation to Ahmedabad, and there are different kind of andrologists. They choose a different technique. Like a 16 dot procedure is also known as a Tom Lu procedure, who is an American andrologist, and he has invented this procedure, and most of the people who are trained by him, they do that. More's pinoscrotal plication is a recent one where very little dissection is done. Those of you who had come to Cochin, there Alan More was invited and he had spoken about his pinoscrotal plication. We will be talking very little about one by one all the procedure, but mainly we will discuss multiple parallel plication, which is a most commonly done procedure because it has almost no side effects and therefore it is to be chosen. Now in Nesbit procedure, when he invented, and sometimes even if you are doing for hypospadias, I will suggest not to do it for hypospadias also, hypospadias curvature, where you actually excise the tunica vaginalis and then you suture it. Now, because tunica albijunia is a very important part of the integrity of the erection, once you excise the tunica albijunia, the erection somehow at some level compromises. Now, in this modified Nesbit procedure, you make you cut like this, and then ultimately by Hanke Mikulis technique, as you know, the transverse incision sutured vertically. By that way, you can close it by taking the multiple sutures. So that is the second type of the procedure. 16 dot procedure, you make at least 8 different dots for one suture and 8 for the second suture. It should be around 4 millimeter proximal to the gland so that gland's vascularity is not affected. And this is known as a Tom Lu procedure. Some of the people in India, they still do it. Here, Tom Lu prefers to use non-absorbable suture material, and this non-absorbable suture material quite often gives a kind of a erosion, pain, palpation, and discomfort during the sex, and therefore slowly, even a 16 dot procedure had also its own modification. So different modification is now there.
You click below at the sound, automatically it will come down. Below one, sound one. Yeah. Click, sir. Yes, sir. It is playing, sir.
Yeah, this is the young patient in Gujarat. Like you, we have a festival of Navratri, and at that time, most of the family allow their female child, the girls, young girls, to be there for because it's a dancing festival for about 9 days, and you might be knowing about it. And the boys and girls meets very often each other. Now this gentleman is about 18, 19 years old, and he tried intercourse with his girlfriend and came to know that he had a significant curvature. So he contacted me with his father, and he we asked him to take couple of picture in his mobile phone when he had a erectile penis, and we did a papaverine test also to confirm. So now this is a multiple parallel plication technique, which is actually preferred by European and Serbian urologists, while in America also nowadays more and more less invasive surgery is preferred in comparison to breast beat. So you can see that we have circumcised it, and the penile skin is deglowed, and buccal fascia. Now we have to start dissecting because many of you, when they have started a hypospadia surgery, I don't know, it was a the way it is a difficult thing to learn that neurovascular bundle on the dorsal part of the penis. Now this is to be entire part is a neurovascular burden, but between 11 to 1 maximum neural part is there, and between 5 to 7 on the ventral part maximum neural part is there. The vessels are there in the central and parallel to that. So when you initially dissect neurovascular bundle, it it can be little bloody surgery because there will be perforator. The you can see it. One can use a bipolar cautery so that the nerves are not affected much, and you have to do sharp and blunt dissection together to separate the buccal fascia from the tunica albuginea. Now we prefer, now this patient had a curvature lower down, and therefore you have to take a plicating suture on the dorsal side. When I say lower down means on the ventral side. On a dorsal side, we have a neurovascular bundle. So you have to do this dissection very carefully, very gently, and patiently. Once you do regular penile curvature surgery, then you don't have to elevate the entire neurovascular bundle. It means you do the penile erection and find out where exactly you need to take the stitches. So on the opposite side with the Alice, you can find it out, and you can elevate only the part of a neurovascular bundle. Dr. Alan More, who is doing a penile neurovascular penoscrotal surgery now in US, he doesn't elevate neurovascular bundle at all. He doesn't circumcise also, and they do plication on the lateral side. So if you have a patient where the little bit of the curvature is an issue, and if you don't want to do after doing couple of the surgery when you are experienced, then one can avoid elevating the neurovascular bundle. So this is the entire neurovascular bundle is elevated because the ventral curvature is there. We will be cutting on the dorsal part. Initially, when the 16 dot technique was started by Tom Lu, the suggestion was to keep 1.5 centimeter distance between the two dots and in that two dot, the non-absorbable suture material was to be used. While in multiple parallel plication, only we will be cutting at the distance of the 0.5 centimeter, that is the half a centimeter, 5 millimeter, and cutting is to be done only on the superficial layer of the tunica albijunia. I am using a sharp 15 blade. It is better to take a new 15 blade if you have not used, and that goes even when you are cutting the tunica, when you are cutting the plaque of the Peyronie's disease. So you can see that I am cutting very superficial the tunica parietalis of the tunica albijunia, and then here we are using the absorbable suture material. One can use the
Sir,
braided.
sir, one small interruption. Are you getting the video in continue or break?
No, this one is a continue video.
Sir,
After that,
we are getting very breaking. Can you close your presentation and optimize the video?
okay.
First, I will close your presentation. Keep it there only. Now, before you start your presentation, optimize the video will come, sir. When you share the screen, optimize the video left down. When you start sharing the screen,
Now, first
first you click the share the screen.
okay.
Then in the screen you will see optimize the video left side.
Yeah.
You have click that and then go to presentation. Two columns will be there. They both will be clicked. Yes, sir.
Is
Now
it okay?
now let me see, sir. It is opening. Just 10 seconds. Yeah, it is better, sir. Yes, continue, sir.
If the video is not good, then I have a source of the video. I can go directly from that.
No, sir. It is showing. At least it is not breaking now.
Okay. So are you able to make out that the neurovascular bundle is lifted and
Yes,
below,
sir.
yeah, below that, the from the opposite side I have taken the stay suture and it is yeah, now I have changed it. So just below the neurovascular bundle, the first row of the plication is finished. So in between, what I have not shown is we need to do the artificial erection by using the scalp vein and inject the normal saline inside, the way you do in any other surgical procedure.
Sir, you
And
are
then
giving an horizontal incision below the neurovascular bundle on the dorsal aspect.
exactly.
After that, you are closing again same direction or
No, I'm closing in the same direction between the two incision. I'm closing it so that there will be kind of a plication, but plication will be very nearer so that shortening will not be there.
okay. But you are opening and closing same thing.
Correct. But uh, see, when I'm opening and closing at that time, I take a loose tunica albijunia with me so that ultimately the way you do plicate, the plication will become. Even if you opening and closing same thing, why we do this? Because otherwise the tunica albijunia length will go away and penile length significantly reduce. If you do like this, then opposite side erection will be the opposite side curvature will be reduced. But you have to do 2-3 line of the parallel plication.
Okay. So you incise three areas horizontally and close with little bit of margin.
Yeah. It is not exactly, it will not start on the incision. It will be about 3-4 millimeter away from the incision on the either side.
And then you pull.
Yeah, then you pull. So That is why it is known as parallel plication, because there are three parallel incision. The one incision will be deepened inside, two will remain, and both from the incision you don't take suture, you take about 4 millimeter away from there, and therefore a minor degree of the plication will be there. It won't be very big plication or cutting of the tunica albuginea. We have cut the tunica albuginea only superficially. So now we have injected and checked the straightening by injecting a normal saline. If one want, one can use a pharmacological erection also to check it at the end of the procedure.
Okay.
So so this the advantage of this procedure is like if we cut and close it, or if we take you cut transversely and close longitudinally, then ultimately penile length significantly reduces. Here the penile length will appear little less in first 6 weeks to 3 months, but ultimately the penile length will be normal. So the long time uh, complication of reduced penile length is not very effective. In India, we are treating majority of the patient by plication,
Sir,
except that
this is applicable only if there is no Peyronie's disease.
no, sir, it can be done even with the Peyronie's disease, you- where where you don't take out the plaque or you take out the part of the plaque. It can be done even in Peyronie's disease also.
Okay. So normally I understood that in Peyronie's disease a plaque will be there, on which side the curvature concavity will be there. So if you excise and close them, concavity will increase. It should be done on the opposite side then.
Exactly. It should be done on the opposite side or on the lateral side. You have a either dorsal or a ventral side uh, uh, of the penis. We will cover it little later.
Okay, okay, sir. Okay, understood.
So the plication procedure is simple, minimally invasive, and it preserve potency in the most because you are not cutting tunica albuginea. Remember that whenever you cut the tunica albuginea, you are disturbing the potency physiology. While there will be temporary penile shortening, and it is most for smaller unidimensional curve. If you have a very complex curve like a hinges or curve which is there dorsally or ventral, and also the rotational curve, then plication procedure cannot work as a single procedure. So it will worsen hinge effect, and therefore long-term result of Nesbit or multiple plication. If you do a Nesbit procedure, the less than 1 centimeter shortening is there in 87% of the people, 1 to 2 centimeter shortening in 9% of people, and more than 2 centimeter shortening in 4% of people. Now, if you do this parallel plication, then over 3 months, even the 1 centimeter shortening is not there. You get about 3 to 4% of patient where there will be permanent 1 centimeter shortening. Because ultimately, tunica albuginea being the elastic structure, initially
એ આપણો અવાજ નથી જતો ને
Hello.
hello.
Yeah, there is some voice disturbance. Somebody, I think, uh, is it your boy has closed the.
No, he is not here. He left the room. He is outside.
Okay, sir, no problem.
Can you see the presentation?
Yes, sir, a presentation is seen.
So now as you were asking that what do you do if there is a tunica, if there is a Peyronie's disease. So, but if they have a strong pre-op erection, curvature is more than 60 degree, if there is a significant shaft narrowing, hourglass or hinge effect is there, and if there is an extensive plaque, then we have to do either PEG or PIG. PEG is a plaque excision and grafting. PIG is a plaque incision and grafting. It is the best opportunity to correct severe curvature, only approach to re-establish girth and correct hinge, least likely to cause further length loss. Now, if you do incision, then if there is a dorsal plaque, you have to do circumcising, but ventral plaque, you can make a directly ventral incision. Ventrally, tunica albuginea is very thin, and dorsally when you do, you have to do neurovascular bundle elevation, partly, at least if not completely, and you can make H-shaped or Mercedes-Benz incision in the plaque. Now, once you make an incision, what do you do? That we will see. Here is a patient who had a Peyronie's disease, and can you see the video? Hello?
You click it, sir. You click it. Ah, yes, it is playing. You click on the play. Yes, sir. Click it, sir, on the play button.
This one is
Yeah.
a,
Yes, yes, it is playing.
original.
You click it, sir. Click it. Click it, sir. Click on that button.
This button?
Ah, yes, yes, sir. It is playing. You just wait for a few seconds.
Okay.
Now, sir, again you have to click on the play button. Play mark.
Yeah, it started.
So this is a little bit intriguing case. We must decide together what we will do. Penis is not so short. It has very severe plug dorsal. It's
Hello?
Yes, sir.
Yeah, this video is a part of our pen recon. Professor Rado
Yes,
is
sir.
doing the surgery, and he had shown the plaque. So now this is a gentleman, as it was written on the history. He was okay with the pharmacological treatment, and he had a good length of the penis, but he was really worried about the bending. So basically, if the patient has a good erection, then battery laga do. If there is a good erection, then one can try with the
Sir, he has deglowed partly.
so here you can see the erection. How much is the curvature? There is a significant dorsal curvature, and the deglowing is not done. The incision is made directly on the raphe, on the penile skin on the ventral part, and this particular is the plaque. This plaque is excising. Now remember, the plaque is there in the tunica albuginea. Then even if you have a big plaque, you will have about 2 millimeter compressed membrane. So you get a tunica albuginea membrane below this plaque. You have to use your knife like a brush, and sometimes you have to change knife 2-3 times, because this plaque is very thick and calcified, and you need to use a kind of a tooth forceps, or sometimes you can use a Ellis forceps also. You can see here he has cut the very thick plaque which was responsible for a significant bending of the penis on the dorsal side. It was like 180 degree. So you remove this small plaque also, and once you remove the plaque, then you need to take the suture on the tunica parietalis, which is left over, and you make a small transverse cut. Now you can see that this is a membrane of the tunica albijunia. He is cutting it like a brush, tunica albijunia, from where the plaque has been taken out. So in a different places the plaque has been taken out. And once, now remember that normally we don't remove the plaque. If it is a small plaque, one can straighten the penis by plication. That is the answer of your question. Can you do plication in Peyronie's disease? Yes, you can do. But its plaque is too big. If there is a calcification, if there is a hourglass deformity, or if it is a significant curvature, then you need to either make an incision or you need to excise it. The problem is you must evaluate the erectile function before, and if with the help of or without help of pharmacotherapy, if patient has a rigid penis, then you don't go for the grafting simultaneously. Now on the base of the penis, again he is incising. You can see that he is incising the plaque. This plaque is not completely going to be removed. It will be incised and left. So ultimately the straightening of the penis will occur.
Sir, I am not able to understand. You have to, he has incised vertically and he is closing vertically.
The major plaque is excised, Chandramohan.
Yes, sir.
Now, the smaller plaque he incised and kept open. He never closed. The closing is done of the skin of the penis. So the plaque part is not closed.
Okay.
It is kept open. Now, if there is a large and calcified plate, you need to excise. And when you want to put a graft, it should be 20% larger. It may need an additional plication suture also. So, like we measure it exactly how much is the area, and then we put a graft. So, now this patient has again a major plate, and there is a significant bending. He is a comparatively young, and his erectile function is good to start with, but the plaque is so big. The first patient you have seen where after the plaque grafting is not done. Now incision on the ventral side is made on the raphe, directly on the raphe. When you do plication, when you do initial surgery, and when you have to plicate on the dorsal side, then you have to circumcise it and elevate neurovascular bundle. Otherwise, it is not required. You can do surgery from the lateral side. So here now he is excising the plaque, and you can see this ready-made graft available. So this graft is suturing on the penis. This is a synthetic graft, and in India we hardly use it. Whenever I go outside, we bring it as a gift or sample, and we can use in couple of the patient. In Bombay it is available, but mostly when I do surgery, I use autologous graft, and autologous graft have a different kind of a choice, like a venous graft, buccal mucosa, small intestine, cadaveric pericardium. Autologous graft need more time and there is a second incision also. Synthetic graft increase risk of infection, and now in 2021 guideline it is not recommended, but still majority of the high volume surgeon in Europe, they use the graft. No evidence that surgical outcomes are consistently better with one type of the graft than other. So it all depends which kind of the graft you are comfortable.
Sir, when
As
you are
I
exercising, sir, when you are exercising, you will go deep enough to reach the spongiosum.
no, you need to go up to the superficial layer of the tunica albuginea only. So you when you exercise, you are actually brushing with the knife, and slowly you take out. Even if the part of the calcified part is there, you take as a second part, but you don't exercise it right up to the tunica. Tunica part uh, will be automatically some part where it will be calcified, it will be damaged, or it will be very thin. So because it is very thin, we are grafting it so that ultimately size of the penis doesn't reduce. Now you can see here I have used BMG, buccal mucosa graft in the patient. Either you can use a saphenous vein patch, which is easily available. If a patient is ready for buccal mucosa, because we have a reconstructive unit where where they can see urethroplasty patient and see that BMG is not that bad, then they are ready for that, and you can see that we have used BMG patch after we have removed the very big calcification. The risk of PEG and PIG is it will diminish rigidity, and sometimes it can produce complete ED also. And therefore, it is very important that you have to evaluate the patient pre-operatively. Shortening is very rare, and there will be temporary sexual sensation. I do advise against the grafting because it's a complicated surgery in men with unreliable rigidity. So if the rigidity is 100% with the PDE5, then I go for the grafting. It is better to offer plication in long penis without a hinge, and if there is a moderate curvature which is less than 60 or 70, then plication gives satisfactory result in Indian situation. But if you have a PD, Peyronie's disease with erectile dysfunction, many of the patients have a psychological problem and they have a erectile dysfunction also, then the only effective and radical treatment is penile implant. You will be surprised to know that in United States, when they did a survey, 75% of the urologists are doing penile prosthesis with incision or with grafting of the or plication of the penis. Sometimes you can just do mechanical because their patient have a two concern. Number one, they do not want penile size to be reduced, and number two, they want 100% erectile function. In India also this is the issue, and therefore less and less surgery is done. But Indian penile prosthesis is available and it is cost effective. And if patient is ready to offer to take penile prosthesis, then some of the big Peyronie's disease can be operated. Mechanical straightening is done by prosthesis itself, or you can do modeling, or you do plaque incision and grafting. Now this is known as modeling. Before you graft, you actually model the penis, and then uh, you can. So this patient had a significant uh, uh, problem, and then ultimately after the Peyronie's plaque also removal, there was he was a totally important. No drug were working. Even papaverine was also self-injection of papaverine was not working. So we have done here inflatable penile prosthesis, because we do get some of the penile prosthesis in as a donation from the international society. So that time in poor patient we use it. Otherwise, nowadays it is for a 1 year in between, it was difficult to get an inflatable penile prosthesis even for a rich patient because of the new guideline of government of India. We do get a semi-rigid penile prosthesis easily. I think all the audience and you know very well about the penile prosthesis technique. So once you make an incision on the corpus cavernosa, you dilate it with the help of a Hager's dilator, and there is a marker or measuring metal rod. With the help of that, on the both side you measure it, and then you take the size of the rod of the penile prosthesis. Here in this case, the prosthesis is selected which is inflatable, and this part is kept in the scrotum, and when he will squeeze, the the prosthesis will start working. Now at this place we are just connecting it, but the function will be starting after 3 weeks to 6 weeks according to the need and type of prosthesis. This is a AMS prosthesis, and it is to be used when you have a significant erectile dysfunction with Peyronie's disease or without Peyronie's disease to start with. So if you remove or do plication in significant erectile dysfunction without penile prosthesis, it is not going to work. Some of you might be knowing that the Clostridium collagenase, which is a kind of a abstract from the Histolotica collagenase. Now this is a first FDA approved medical treatment, but the problem is cost of one injection is $4,000 and you need to give about 8 injections. So total cost is $32,000 apart from surgeons or physician's fee to give the injection, and the success rate is about 30 to 40%. In India, most of the people can't afford it, but there are people who can afford, where we can get it in grey market from the Bombay, or you can get it from Dubai. Officially Xiaflex is available. And here I'm talking about if you have taken Xiaflex and after that if the Peyronie's disease is still there, then there are paper that says that surgical reconstruction is still successfully performed. Xiaflex is a medical treatment, injection treatment in the plaque, and it reduces size of the plaque by 60%. After you do any kind of the surgery, you have to advise vacuum device. Penile extender device is available outside the India, but in India we get easily vacuum device. All the patients get a 5 milligram tadalafil or 25 milligram of sildenafil, and then they can maintain a good vascularity with the help of that. Type of the surgery is individualized and tailored. I again repeat that plication is most common and least harmful to the patient. At the same time, some of the patient you can't do plication only, you have to, because if the plaque is too big, then you have to excise it. But as far as possible, if you do incision, then it will help evaluate the patient to start with, and if patient has a significant erectile dysfunction, then I use Shah penile prosthesis simultaneously. So patient's goal and expectation is the deciding factor. If a patient has come to you for erectile dysfunction and you just reduce the straightening, he is not going to help. So that is how ultimately you choose the type of the surgery. Thank you very much, Dr. Chandramohan, and all the entire audience. I believe you could see the video and
Yes,
the
yes.
major part of that.
Yes, yes, sir. I will ask some questions, sir.
Sure, sir.
Sir, I understood clearly that in these videos, as a first step, when you are evaluating a patient, 90% of the patient will have less than 20-degree angle we ask them to get the pictures. If in erection, if we can straighten the penis and can insert into vagina, if the pain is not there, we should not operate.
I agree, exactly.
Number two, if curvature is a bit too much and if he is having pain, you like to see his normal erection in a photograph, and if you feel that you want to operate, I want to ask a question. Will you deglove in all cases before erection, or you directly induce erection without degloving? This is my first question.
I will induce the erection without deglowing.
And if you are able to see the plaque in one region, you will directly go to that area or deglove it.
No, all the patients do not require deglowing. Deglowing has its own disadvantage of loss of temporary sensation after the surgery.
That means, will you give vertical incision, horizontal incision in a localized area? Which one you prefer, sir?
I will give a what in the side of the penile raphe, so it will be a kind of a vertical incision, but it is only possible when you have a dorsal curvature and you want to operate on the ventral side. On a dorsal side, when you have to take the stitch, then you have to deglow and take care of the neurovascular bundle.
The foreigner which you have shown second video, he was retracting the skin half cut with difficulty and excising. Do you advise in such case injury to dorsal neurovascular bundle may happen? He may be experienced. Do you advise such type of extensive excision without degloving?
When anybody is operating first 8-10 procedure, they should do, especially when a dorsal part, they should do with a deglowing and elevating neurovascular
Yes,
bundle.
sir. I got the answer, sir.
And after that, you can do it from a lateral side.
Yes, sir. I got the answer.
Yeah, he was doing it from the lateral side.
Yes, sir. Now, my third question, when you examine the plaque on the dorsal part, where patient will show in the distal part, mid part or proximal part, just at the level of pubic symphysis also, they will hold and feel, sir, I am having hard feeling here, I am having pain. So, how deep you have to deglove to go to the most proximal penile plaques which are situated exactly over the dorsal central part, they will be there. Do you feel any difficulty in lifting the neurovascular bundle in such cases in more proximally? Because any injury proximally is a disaster.
Exactly. Now, when you have such kind of the plaque at the base of the penis,
Yeah, sir.
now it will be having a kind of a hinge or a hourglass deformity. Usually this deformity are not only one side, but there will be rotational deformity also.
Yes.
So you have to remove the proximal plaque and distal plaque, and during distal plaque, when you elevate it, it will be, you need to remain very careful, and if you, after the base of the penis, you should not elevate it, but you should take the stitches little laterally, because the nerves are between 11 to 1. So you leave that part and take a lateral plicating suture at the base of the penis.
Okay. Because you cannot lift so easily at the base of the penis.
Yes, the extreme part, as it happens in many surgery, there are people in United States of America that they do not deglow, and they make a small incision exactly opposite to the banding, and they take a multiple kind of a plicating suture. But in that case, ultimately the plicating sutures are so many, and finally the length of the penis reduces. For them it becomes a easy surgery, but for a patient, length of the penis reduces. So for a high volume surgeon, where patient goes as an expert, if he does a mistake, it is all right. While in India, all of us when we don't do exclusively penile surgery. We do as a part of our routine urological surgery. So we
Yeah.
have to offer a very careful result to them. So in that case, you have to elevate the neurovascular bundle up to the base of the penis only. After that, you, if at all you require, you take a lateral sutures.
Sir, usually on dorsal side it is more common or ventral. I have seen most of the times dorsal plaques. What is your experience, sir?
No, the plaques are more often dorsally, and if the plaques are dorsally, then there will be ventral curvature.
Yeah.
Only in the congenital it is reverse, but this is kind of a 70-30 ratio. So you can get any kind of the thing in peronis. Sometimes you get a reverse also. So you should be prepared to handle both the way. Uh, Commonly, when you see more number of the case, you can make out that more often dorsal plaque is there in peronis, while in a CPC, congenital penile curvature, you will be surprised that many of our doctor friends are also having it, but because there is no awareness, they will ask the urologist and they will say, no, 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 it is psychological, it is okay. Unless you do a papaverine induced injection, pharmacotherapy induced erection, you don't know exact problem, and sometimes even a educated person will have a difficult intercourse. So that checking
Sir,
part.
I agree, sir. Sir, if you have a 2 centimeter by 2 centimeter in the mid shaft dorsal plaque, very clearly palpable, you scrape it. Do you put graft or do you plicate simply closing that horizontally?
If a patient has a good erection to start with,
Yes,
or
yes, good erection. Patient wants erection.
yeah, if no, no, how is his pre-operative erection?
Good, but painful erection because of the curvature. Middle aged, 33 years.
Chandramohan, we should operate only after the pain goes away. If there is a pain, it means it is an unstable disease.
Sir,
So
how to stable that?
you give a local steroid, you give a different kind of a medical treatment, and you wait. If you
You,
wait, when the patient has a pain, it means it is an acute disease.
you should
During
not operate.
we don't operate in a acute disease because your judgment will be wrong. The plaque can increase in the size later on, it will remain the same. So if you operate, patient won't always a permanent result. If his result will disappear, a problem will be again after 3 months, they will come and complain to you. So in a painful situation, we should not operate.
So, do you think the pain will decrease with medication and he will come in interval period?
The majority of the time, as you, if the patient comes consistently to you, like if you give an anti-inflammatory drug and other drug, the over 6 months the pain goes away, and 6 months to 1 year it takes for the stability. After stability only you operate. If the patient is in hurry, then it is better not to take out that 2 centimeter plaque. He has come because of the pain, and if you excise the plaque, he may get a plaque again after a year, after 6 months. So when it is painful, it means disease is still just progressing. The disease itself is a
So, okay, sir.
progressive.
After the pain is decreased, if the plaque is persisting, what is your in an young patient who has a 2 centimeter mid shaft with dorsal peronis disease? After opening, you feel a hard plaque. You will scrape it and take sutures, or you will excise deeply and put a graft. What is your if the patient comes to you, generally, what is your practice?
My first practice is to plicate it on the opposite side. I will multiple sutures I will take because my job is to straighten the penis. I will discuss with the patient that this plaque will remain and you will palpate it. Many of our Indian patients are not ready to accept that because they have a fear that it will be a cancer or something like that. So we have to reassure, and at the most, if required, I'll just make an incision so that the penile length is not reduced. I won't excise that.
Okay, this is a major point we learned today.
Yeah.
And if multiple lesions are there, what will you do, sir? one you see, you will see, sir, I have feeling here, I have feeling here. We feel all of them hard, nothing soft. Entire length sometimes feel hard.
Then you have no choice than to excise the major part and put a graft on that.
In that case, you should be ready to lose erection.
Exactly. So if you take out that and if his erection goes away, if he has 180 or 160 hinge deformity and he is not worried that even if his erection goes, it is
Yeah.
okay.
Some
Then
people
only,
come like that.
yeah, they come and say, like one patient which I have shown here, he is telling that erection is not a problem anyway. After 60, they become religious. Wife is not allowing. So many reasons in India.
Yeah.
So they don't want, but they are worried about this bending of the penis, and they don't want so much of the bending. Then you can operate them and always tell them that when you have a worry for erection, come back. We will do prosthesis for you.
And when last question, last couple of questions, when this disease recurs, it is painful to explain them. If another area, if he gets pain and then some amount of discomfort with partial erection and pay while normal time also, have you got any experience of reoperating, taking your 30-40 years of experience, reoccurrence of Peyronie's disease and then reoperation, which is
Yeah.
painful?
Especially when I have hurried, some patient want a very rapid treatment, and when the disease is not stabilized and I have taken the patient for the surgery in a hurried manner when the pain was there, the patient come back with the second plaque again. So there will be a recurvature again, and they will blame the first surgery. But because the disease is progressive, when there is a significant pain, one should not take that patient for the surgery.
Sir, what medication you give, we want to know, sir. Steroid means what steroid, how much you inject, with what needle you inject, sir.
No, the only in a painful condition I use a Canacort injectable in the plaque. Otherwise, most of the time I give NSAID or a anti-gout tablet Gautanil, because that anything which reduces pain. The general NSAID do work at that time. Vitamin E also works, and lot of other drug, but this drug will never reduce the plaque. If a patient is affording, then one should try that Jayaflex injection.
Is
We
it
have
available in India, sir, Jayaflex?
it is available in India. The officially it is not sellable, so they may not get bill and everything, but you do get a Jayaflex in India.
Okay. So overall, this surgery, I feel, is still complicated and must be done by experienced person. Those who are concentrating on these type of surgeries, better to be done by them, or you can say that after watching 2-3 surgeries, a general urologist can attempt.
Not 2-3, but at least if they keep on reading about it and see the video, after seeing, like after today's lecture, what I want to say that what is happening now in India, that suppose in Hyderabad one person is doing it, but rest of the other urologists are not doing it. So if that patient goes to urologist who is good in endourology, if most of the time he will say कि पेरोनिस कुछ नहीं होता है इसमें, तुम मर जाओगे, तेरा तो पेनिस ऐसा ही रहेगा, फिर से हो जाएगा. So it is not like that. There are people who can understand the disease, who can talk to the patient. Then I believe that 4 out of 10 patients, simple plication surgery works in Indian setup, and you give a pharmacotherapy to them, so they are happy, because if their bending goes away, especially in a younger patient, then there is a big help to them. The plaque is to be taken out, and at that time, if you are not comfortable with buccal mucosa, you use a syphilis vein graft, and then it works. You don't have to get an artificial graft. Artificial graft, we get it just from our international friend only. In Indian market, it is not easily available.
Okay. Is there any role of dermis, inguinal region dermis?
previously people were using it, even a prepucial graft was also, prepucial mucosa was also being used. But now the best one is found out as a venous wall, syphilis vein, and buccal mucosa. These two are commonly used.
Okay. So it's a complicated topic, sir. I tried to ask whatever the basics I know. Next pen recon we will come. If possible, we will see this at least plication procedure. It looks simple, but we should attempt with caution. I am not experienced, so I have learnt a lot of things. Nearly 200 audience have participated. One of the very good audience. Lalit Shah sir has asked that in Peyronie's disease you are correcting only curvature, not the plaque in the initial part of discussion. Now it is very clear that as much as possible, if the plaque is not very big and stabilized, try to do in an initial level plication. You told many times. He told it is very good presentation. Vivek Purgani, everybody said that very good presentation, got good knowledge. Thank you very much, sir. Really appreciated. And you have lot of other surgery in future. We will discuss one more surgical technique. Let's hope the younger generation will develop interest by these surgical videos and talks by seniors. Thank you very much, sir.
Thank you. I am indeed thankful to you,
Sir,
for generating this type of interest, and every day at 5 o'clock, if you do academic work like this, it is indeed very unique, and I really congratulate you.
thank you, sir. In fact, this video YouTube link will be forever there, sir. Forever. 100 years, 200 years, maybe it will be there, so that anybody wants to re-go and watch, they will get knowledge and they may apply it, because all these seniors may not be like teachers like you in the future generations. That's why YouTube videos are very useful. So hope so that will be useful for especially those PGs who doesn't have any exposure in their PG time this type of surgeries. Even I have not seen in my PG time, so it will be useful and we get more knowledge. Thank you,
No,
sir. At least.
My request is there that if you, in your OPD, if you see a patient who is hesitating to tell about his erectile dysfunction part, please ask him to lie down, see him, palpate him,
Yes,
try
sir.
to induce. Don't just tell that it is
Yeah,
a
yeah.
psychological.
Yes, I
That is the
really mean
request
it.
of
I really understood what you mean. It is coming from your heart. I really appreciate because of your concern toward patient. We should not say testicular pain or erectile dysfunction, just go, nothing will happen. We should not say, especially endourologists, we may do that in busy practice. You are giving a clear message that if you wanted to treat, please examine and then address properly what is the problem. Otherwise, refer to somebody who is regularly doing that.
Thank you, sir.